2000. So many of us should know, but just in case you're new to the field or new to this work, about the time we started this is CDC provisional data. This just gave us a glimpse of what it looked like. As you can see here on the map, Missouri was one of the highest states that had the drug overdose deaths that were fatal drug overdose deaths. And so when we started this project, we were seeing many individuals that were dying from overdose, and even a larger scale. We probably still to this day don't even know how many individuals were experiencing overdose and surviving that. So for those of you that are familiar with the area, this map should look very familiar. Our service area is right down the I-44 corridor. So you can see at the kind of my right of the map is St. Louis County. And so anytime that I speak about our overdose deaths, I want to show that in that time period of when we started, when you look at a rate per population, our counties were experiencing fatal overdoses just as high as St. Louis County. And so it's always been important to me growing up in rural, working in rural, that rural has that same voice and that same being looked at as even the urban communities. And I like to say that, my rural lives are just as important as those in urban, and they are just as important as rural lives. It goes both ways. But when you work in rural areas, a lot of times our people are forgotten. And I think until you don't show it on a map and what it really looks like, individuals in those leadership roles or their advocacy legislation roles really don't understand it. And so this is one of my next favorite maps that I love to show individuals. And so this is, I believe, in 2019 data. This shows the number of Suboxone providers in the counties that we serve. And as you can see up in the St. Louis County, you have lots of red dots, lots of access points. But when you come out into rural, very few. Many of these dots are the same provider, just able to provide treatment in the same counties. And so when you look at this, when we first started, access was a huge issue when it came to treatment. And so when we first started our coalition in this area, it actually started with 5 community partners coming together and saying, hey, substance misuse is an issue. We want to be a part of the solution. What do we do? And 2 of those main partners was actually a health department administrator and a non-for-profit administrator. And so they were 2 large voices in this project. And so that's all it really took was this small group to be committed. And so they wrote an application. It was first the HRSA RCORP planning grant and was awarded that in September of 2018. And that's what formalized the Your Community Cares Health Coalition. To date, we actually have grown to over 20 members. And as you can see from some of these logos, we have, of course, the hospital, the medical, the mental health, the health departments, but we also have the prevention group that is contracted from the state. And then we have schools, we have law enforcement. What you don't see is we actually have individuals that are in recovery and family advocates that also are part of our coalition. And so how we wrote that, I know some of you might be new grantees, is, you have to kind of do those bylaws, is the five main original partners have kind of those voting rights. But everyone else is invited to the meetings because it's those individuals in those 2 communities who truly understand what's happening. I live in Rolla. I don't really know, and I don't see the day-to-day in Salem, Missouri or Stillville, Missouri, but my law enforcement, my hospital, my schools, they see it every day. And so they come to the table, they bring the knowledge, and then they bring the information. We make decisions as a group, and then we move forward with that. So that way we have those voices of what's happening directly in the community, impacting the decisions that we're making. And I gave you the population. I think sometimes people don't really realize what rural is too. So between the 2 counties, we serve about 40,000 people. A lot of those individuals are transparent. And so, or transient. And so that way they go back and forth. So when we sat down as a group, we really couldn't figure out what was our first original goal. Again, back in 2018, you saw the state of Missouri continuing to increase every year with the number of those fatal overdoses. And so our original goal as a whole was just stop the percentage of the fatal overdoses from increasing. We felt like we really couldn't decrease, was ultimately, that's our goal, is right, to decrease that. But because the amount of increases every year, we didn't feel like we could jump to that. So our first goal was to decrease or to stop the increase. And then after that, we would continue to decrease. But then when we sat down and talked about like, how are we even going to overcome this? Well, first we recognized we had to start by changing the conversation in these communities. There was no way in 2018, 2019, we could go into these communities and just start treatment because we didn't have the right language and the right conversations happening for the local community to support those efforts. So the first part, that planning grant, of course, is about the education and the awareness and the stigma. And we even continued to do that in our first year. We continued that in our first year of implementation. And so with that, we've done lots of different events. And I wanted to highlight these because I think sometimes it's hard to understand what training or what education you can bring into your community. So I noted some of these for you. So in our planning grant, we did a lot of what we called community conversations, and we actually devised a survey, and we use those surveys for those needs assessments that we have to do for our HRSA requirements. And so we actually not only pulled in federal, state, but we pulled in local data, and we pulled in local answers from the community members that came to our event. So that way, again, their voice was being heard in our project and being seen from multiple individuals at different levels. One of the best things that I will always remember was our town hall. We actually were very fortunate to have every member of the criminal justice system in our local communities come and sit at the table. So our chief of police, our sheriff, our prosecutor, leaders of the drug task force groups, doctors, you name it, we had them sitting at the table. And it was it was a hard time because many lives are being lost to overdoses. And so we knew in advance families were coming into this town hall, and they actually brought pictures of their child, stuck it on their tables. And so when they were asking our criminal justice system questions, the individuals are having to answer and look at the pictures of these loved ones lost. And so it was very eye-opening and very emotional time. And so a lot of people walked out upset and frustrated, but it actually opened a dialogue. Is one of the best things we could have done, because to this day, individuals in these local towns are able to call up the sheriff or call up the chief of police and just express their frustration or ask the questions about, the big thing was, why do you let drug dealers continue to deal illegal substances to our children that are killing them, right? And so it was a very hard dialogue to have, but it needed to happen so that way it could build trust and respect, and so that each side could share their frustrations, and then the other side could understand where that other side was coming from, or how their hands were tied as well. One of the great things we did for our law enforcement was we brought in training from the city of preventing additional trauma to children impacted by substance use. It was one thing that they really appreciated having. We did trauma informed, of course, Narcan training. And the one thing about bringing education, it was so important in rural communities to bring that to the people in the areas, because they valued it more when it was face to face. But it also allowed the people in our rural communities to train those coming from the urban areas. In one of our trainings, transportation was brought up, and the trainer said, hey, why don't you all just put some money together? Each of you, put some money in a pot, and then you can pay for Uber. And quickly did she learn we don't have Uber in our rural communities, let alone even taxis. And so it allowed those individuals to go back to their urban areas or to their leaders and truly give them an understanding of what rural looks like, because it is so different. And it's up to us to also train those individuals. Some other things that we did is through National Recover Month, these two pictures on my right, we created these signs and had the purple ribbon, and it says, together we stand up to support those in recovery. And we went to our businesses and our law enforcement and our hospital staff and anyone and everyone who wanted to be in a picture that definitely had a leadership role in the communities. And we took their pictures with these signs and we posted on social media. And I never would have thought the reach these pictures would have had, because everybody in these local communities were sharing these photos, and it opened up, again, another form of dialogue to show the community that, hey, we want to be a part of the solution. We want to be a safe place. We want to help. And so that was one thing that didn't have a lot of cost and went a long way in our communities. And then one thing to remember when you're starting your plans is don't forget the workforce group. Those are the individuals that are hiring people in recovery and giving them employment, but they don't have a clue what they're dealing with when it comes to substance use. Typically, they don't. A lot of times, our policies and procedures are written to not be recovery family. And so we have to educate and we have to train the workforce, the employers, what this looks like. And so we hosted a summit, a Opioids in the Workforce Summit, where we were able to have open conversations and dialogue with our local businesses about what this looks like and how they can best write their policies and procedures, so that way their language within their policies and procedures is looked at from a second chance versus just a dismissal, depending on situations. The other thing that was really important, again, when I talked about we had to change the conversation, we had to change the language. Individuals were speaking in terms and using terminology that really, you show a picture that you support us, but then when you talk to us, you use words that are downgrading. So we created these really awesome change the language cards. Language matters. These actually fold in half. They're just a business card size, and it just reminds individuals, say this and not this. And I think at times we mean to say the right things, but the words come out wrong. And so it's just a good, friendly reminder about that. And so we've handed out over 5,000 of these cards in our communities for people just to have on them or leave on their computer, whatever's best. And I also wanted to share some unique partnerships that helped us build to capacity of our ultimate goal of the mobile unit. And so we had a really unique opportunity to partner with a Fidelity Communications, which is our local communications. And so it was really important that, again, we share messages of individuals from our community. So I just wanted to show you 2 examples of what those looked like. So during those first year, we really hit on this shatter the stigma, shatter the shame, because again, we had to start having conversations in the community. We had to have people talking about it, because if we didn't do this, no one's going to know what this mobile unit's all about, or how do I refer that, or what is it. And so we had to, again, create conversation. But how do you share your local stories? How do you share the people that might not necessarily know that their child was involved in such a thing, or that them themselves? And so we created these radio commercials. So we have about a half dozen stories from people in the community who then are recorded by other voices. And these were played over our local radio stations for us free of charge during National Recovery Month, to go along with some of these commercials. I'm going to show you one of the commercials we did too. Oops.
Hey, Felisha, this is Derek. I don't think you're having volume come through.
Oh, seriously? Whoops. Can you hear me still?
Yes, I can hear you, but the videos weren't.
Well, I'm just having all sorts of technology issues today. Any thoughts on how to get them to play through the sound?
Felisha, check when you shared your screen, sometimes you also have to click something else to share audio. for like the presentation, if that makes sense. I can't remember where it is, but I've had to do this in the past. I know where it is in Microsoft Teams. I can't think where it is in Zoom.
Derek, you don't have any thoughts? Share sound. Oh, I found it. Okay, let's try this again.
Perfect. Yeah, I was just
When
trying
your children are born, you dream.
Could you hear that?
yeah, but it was pretty staticky, so maybe let it play for a second.
Okay.
When your children are born, you dream about the great person they will become. You strive to keep them safe. And on June 22nd, 2019, my beautiful son took his last breath. He was ripped from us by fentanyl overdose. Now my son is remembered on purple ribbons, t-shirts, and posters. I do not want one more parent to have their child condensed to an overdose memory because of this epidemic. Please ask for help. Shatter the stigma. Shatter the shame. Talk about it.
Okay, so now I'll show the TV commercial.
I started out with just smoking weed, and then it got into meth.
I lost my self-respect more than anything.
I ended up taking my kids into state custody.
There were days I would curl up in the fetal position, crying like a little girl because I didn't know how to do my dishes without drugs.
Whenever I was prescribed prescription pills, it was pretty much over.
I know where you've been. I've been there for almost 20 years.
Just because I end up being a failure at something doesn't mean that I can't do something else and, be great at it.
Find you one person that you can trust. It doesn't matter what you look like. It doesn't matter where you come from. It doesn't matter how smart you are. It touches everybody. It's not worrying about the stigma. It's taking care of you.
It's easy to reach out for help. You just have to be willing to take that first step.
So again, we had these radio ads, different stories playing on the radio. And then this was a huge accomplishment, the TV commercials, because these are actually 5 individuals from our local community sharing their story on the local television station, which was really huge for accomplishment in rural areas. Because again, we are great about knowing everybody, but we are also great about not knowing stories about families. And so for them to share their message and it be an outlet that they couldn't control or have conversation was a huge overcome when it talks about shattering stigma, shattering the shame of sharing your story, asking for help, and they led that way. And so again, we had this unique partnership, so we were able to create these different commercials and different avenues where we could share these stories and let people know that, we are serious about providing treatment and providing solutions to these problems.
When your children are
So as we're developing through this stigma and education and breaking down these barriers, we were then writing for our implementation grant. It was kind of an odd process at that time. You were writing your implementation grant about halfway through your planning grant and really didn't really know what you were gonna do. And so we knew as a FQHC, we weren't in a position necessarily to open up multiple brick and mortar offices in these local communities, but we still hadn't really realized what's the number of people we can help, or what does that even look like? And so we kind of went in a little bit blind because we weren't through that planning process just yet. And so we devised a plan where we couldn't go there brick and mortar, but we could go to multiple communities through a mobile service. And so that's when we decided we were going to write our application for a mobile unit. And then that way we could reach them that way. We were going to staff it with a couple staff members. We could do telehealth if need be, have a provider. And so we wrote it, and thank goodness we were awarded that. And so this is what our mobile unit looks like. So when we go through the process of building this, it was really important to me If you have not seen our FQHC in Rolla, it is just gorgeous. It's very nice colors. It's very bright. It's very clean, very open. And it was really important that when we designed our mobile unit, that no matter whether you were walking in our clinic in Rolla, or you're walking on our mobile unit in whichever town it was in, you got the same welcoming atmosphere. And so as you see the outside bright colors, it follows the YCHC color scheme. And we just wanted something very basic because, again, we're dealing with rural individuals, but at the same time, very welcoming. And so then when you walk in on this top picture of the two smaller pictures, you can kind of see this is kind of where you walk in. There's are kind of like these bus chairs so people can wait if need be, but you can see the floors are very welcoming, the lights very bright. Again, the color scheme matches that of YCHC, but it's not that overly green or overly blue that kind of makes you think of school colors. It's a more of a calming green, calming blue, different shades of that. You can kind of see the skylight here in this top picture. That is not something we paid for. I get asked that a lot. That's actually a signature of the company we went through. And then this bottom picture kind of shows you just one of our rooms. And so again, we picked, if you look at this picture actually reminds me of fall time in Steelville, Missouri, because of the old highways and the change of colors. And so we picked even our pictures that are throughout the mobile unit to make you think like you were in our hometowns. And so it just made it be a part of the community and part of the culture there locally. And so that was really important when we designed this. And so I'm going to show you the kind of sketch of our mobile unit. So where this gray box is on the bottom of the picture, that's the ramp to go inside. And so again, you've got your intake area. So those are where their two kind of old school bus seats are. We have a lab right there and we have equipment. So we can draw labs, we can run them, and then we can send them off to our lab when they're ready to go. And we actually have drops in our local communities. So our staff can just go and take care of those right there. They don't necessarily have to go back to the clinic. We have a restroom because we know doing urinary analysis are important when it comes to behavioral health services. So we've got that set up. And then both rooms are very similar in their design in that the chairs are universal, so we can provide different services. We designed this so that way we could provide dental services if we wanted to. We haven't done that yet. It's a goal of mine. Maybe during year 3, we'll get to do that. But so those chairs can go either way. And then we have the dental equipment, mobile dental equipment as well that can be utilized for dental services. And then the very top right is storage, and there's lots of cabinet space and different areas for storage. And so that's kind of what the layout looks like. So we, couple things to think about if you're going to think about doing mobile is another reason why it's so vital to not just create a mobile unit without engaging your community is you have to have a location to put this. Again, you're not having brick and mortar. So where are you going to park your mobile unit for what your schedule looks like? And so those partnerships and relationships are very valuable because we were able to park our mobile unit at 2 locations free of charge. Both communities allow us to not pay for electric. The city covers the electric, and it's not much, but every little bit when the community combines in is just as valuable. We're able to fill up with water free, and then we utilize city dump stations to dump our sewer. And again, those are all free of charge because of those great relationships we have with our partners. So when we went with our partner to the city to ask for that, it is no questions asked. It is accepted and approved. The other thing to think about with your locations is think about your rotation for follow-up medical care. So like I said, we serve 2 communities currently. We serve Salem, which is in Dent County, and Stillville, which is in Crawford County. And so we currently rotate every other week. And so that way as our MAT medications, with our Suboxone medications, those providers can see those patients every other week, especially for newer scripts. And then we're getting ready to add a 3rd location here in September. We'll be going to Cuba as well. So we're still kind of figuring out, will we do 2 weeks in Salem? So that's 2 weeks in Dent County, and then 1 week in Cuba and 1 week in Stillville, or do we just want to try both weeks in Cuba? We're not sure what that looks like just yet. We're still having those conversations. So originally, again, like I said, the application was written to provide face-to-face and also telehealth. But we also know when you start a mobile clinic, it's not, they just don't come out in hundreds to get services. Because not only were we dealing with the culture of, just rural, we were dealing with the culture of individuals that medical care is last on the priority list. It's about the home, getting kids to school, getting kids fed. And so we're changing the culture through these conversations, just not about addiction and substance misuse and what substance use disorders mean, but we're changing a culture that medical is a priority to our lives and to our everyday, and that we need to be healthy. So all those other things we can do. And so we actually decided at the beginning to start out with telehealth. And so we purchased TIDO equipment to be placed on that. So it's actually really interesting. It's a basically iPad for the communication piece between the patient and the provider that's at the Raleigh clinic. But then it also comes with lots of different tools so that way they can capture digital sounds, digital pictures. So the provider can actually see and hear what the nurse is seeing. So it's actually a really cool setup to provide mobile care when the provider isn't right there. Our staffing plan today is a full-time nurse on the mobile unit, full-time peer support. And then our physician assistant comes out 1 day a week for each community. And our LPC comes out 1 day a month for each community. And I'll talk a little bit more about that here in a second. So year 2 hit, as most of us know, COVID was hitting at that time. And so what that meant is we couldn't do education. We couldn't continue with awareness. We couldn't do things in the community. Everything was kind of just an odd time. So it really forced us in year 2 to really push as hard as we could on treatment. And so that became the focus is, okay, so we can't do all this. So we're going to focus on getting people seen. And ultimately that is the goal. But it's still, you don't break down stigma, you don't break down barriers and create all this education awareness in just a year or 2. So we needed to do both, but we couldn't. So we started full-time providing services on the mobile unit in October 2019. So we haven't quite been in operations for a year. And those first 3 months, all we did was medication for opioid use disorder services only. So an individual would come onto the unit, the nurse would provide an assessment, they would get them on telehealth, the provider would see the patient on telehealth, provide the medication, the script for that. They were then referred to our peer support, our counselor in Raleigh, and provided those wraparound services. And so as many of you know, Missouri is a medication first model with wraparound services, and our clinic has adopted to that. The other cool thing that I think is amazing for our clinic is we are an open access. So we don't necessarily have to schedule those appointments for those medical appointments for MOUD. Now, that doesn't mean we won't schedule, because we also understand individuals in recovery going to work and having a schedule is important as well. But for individuals who are maybe new into their recovery or just now seeking recovery, we want to be able to provide that access point without having to figure out when to put them on a schedule a day, 2 days, 3 days later. So that's why we do the open access. So in those first 5 months, we saw 70 unique patients. And again, that first 5 months was mainly MOUD. We didn't start our face-to-face medical primary care services until January of 2021. And so again, she's a physician assistant that goes out there 1 day a week to do those face-to-face. And so I just wrote down a couple things here for you about what does that look like? Because I think when we were first having conversations about mobile medical, it was really hard for our providers to grasp, what does that even mean? And I am very blessed to have the physician assistant that we do. She pretty much just takes it as is and tries to help the person as much as possible. So you can see we've done sore throat, we've done UTI, we've done STD testing, we've done respiratory issues, anxiety, bone, I'm not sure, bone issues, I guess, contraceptives, PAPs, well check. So we've already done a wide variety of services because, again, we're there to break down all those barriers and not create new barriers just because we're trying to do medical in a different way. And so she's been great at really just meeting the patient with what they need and where they're at. A couple weeks ago, they did a small, I think, cyst removal, I believe, which was really interesting to hear about, and really excited to, again, that we can just provide medical services. That's at the end of the day, we're just trying to make people healthy. And so I will tell you to date, we are now up to probably about almost 170. And I'll get to your question here in just a second, Lisa. We are up to 170 unique patients that have walked on our mobile unit and being taken care of. Now, as we all know, providing behavioral health services, SUD, we have people that relapse, or we have people that don't come back. And so, we're pretty proud of the number of lives we've touched, even though they might not return. We've at least helped them be healthy in a short period of time. And hopefully when they're ready for that again, they'll come back and see us. With COVID, that's been a battle. I wanted from the very beginning, let's test on the mobile unit, because what better way to tell the community you're here to help with COVID. And so we weren't doing anything COVID related on the mobile unit. And a lot of it was just because of capacity, because we actually, as a clinic, we opened up a drive-through testing at our Rava clinic. And there were days to the height of COVID, that way, not now. We were testing 200-300 people in a day, and it wore us down very quickly. We had to have all the extra staff for outside drive-through because it was just so much. We are thankful we're next to a movie theater, and that movie theater parking lot was just filled with people with COVID testing. And so we really didn't push hard just because, our clinic was so overwhelmed. And so now we actually are offering testing. So they take supplies out there, and if people need tested, they can come up, and we do it in the car. So we don't have them come on the mobile unit. And then if they need vaccinations, we try to get an idea of how many of those we need ahead of time, and she'll take those out there, and we will do vaccines. We try our best to, I'll get into some marketing questions in a second, Lisa. We're trying to do our best to use the vaccine, use the vials as much as possible for the number that we need to have. And so we prefer, our medical director prefers all COVID related things to be outside the facility, whether it's in Rolla or our mobile. So that's why we do car visits for all those services. But we did have, when we had our mobile unit built, it has some extra, and I'm so sorry, I'm not an engineer or mechanical type of person, but it's an air system thing with extra air filters that met whatever standard. And so they can turn that on every day, and it helps filter the air through a different filter that's supposed to be safe and better for COVID. So I'll just move on from that.
That's awesome, Felisha. It really is. I am so excited for that, and for you guys to have completed that. That's really neat.
Yeah, I honestly, Lisa, I don't know its efficiency, but again, we try to keep all that outside of any of our facilities. So we're trying to keep everyone healthy and safe, and keep our clinics clean, so that way our dental patients and everyone else feels comfortable coming in still.
So when you talk about the wraparound services, are all of those services and resources available on the mobile unit?
Yep.
Or are you referring some of that to your partners or to community action agencies, or?
Yeah, so we, our peer support's full time on the mobile unit. If she needs to meet a person in the community, she'll arrange that. She works for schedule. She's not necessarily assigned 8 to 5. You can't leave the mobile unit. We want her to be flexible to go meet patients, but also meet new patients on the mobile unit. And then our LPC will come out once a month to each location to do face-to-face counseling. And then if we need any other medical services when the PA is not there or counseling services, they will TIDO back to the clinic. So reverse, we get the provider on the TIDO at the office in Rolla, and they will see the patient when they're not there in person. We're not doing a lot of that. It's really hard for individuals to grasp that process. I'm not sure why, because during COVID, we did a lot of telehealth and a lot of, tell us way of doing services, different platforms we use. But our nurse is getting better at, if someone comes on the clinic, we just take care of them, whether it's TIDO or face-to-face. Now, if it's something that the team feels more comfortable that they need to go to Rolla for and more in a faster response, they'll definitely get that scheduled and referred. So that way it can be more, if it's something that needs to be more timely in a face-to-face environment.
That sounds awesome.
So I had a couple of questions about kind of marketing and those things. So one thing that we knew from the start is our current SUD patients were going to be our marketers. I think as many of us know, if you work in the field with individuals, our providers feel like MAT services is the only thing that you truly know immediately you've saved someone's life. Because as soon as you get them started on Suboxone and they feel better and they're not going through that withdrawal, they feel better. It's the fastest medication probably out there. And so the patients then love the team. They love what they do. They love the recovery. They love the support. So there are marketers. There are everyday referral sources because also they know the individuals that are suffering through addiction. And so that word of mouth is the prime marketing tool we could have ever thought of. But then also is their family and friends. And so what's great about our providers is during that appointment for the medications, they try to do best at other medical issues that is appropriate within that time slot. But then a lot of times our patients are like, hey, we get to know them. And so they're like, hey, my mom's not feeling good, or hey, something's going on with my dad. And our providers don't provide, medicine during those, but they say, hey, bring them up here. We'll take a look at them. And they do. And so now we're serving a family. It's not just about one person or one unit. And, when you start taking care of the health of a family and that family unit is then healthier and they're, in a better place, they definitely spread the word to individuals about what we're able to do. And so we're really proud of that component that we're able to do that. And so I wanted to touch base a little bit about referrals because here we are. We had our mobile unit. We just got it. COVID's hitting. And my Salem hospital that used to have multiple calls for overdoses or individuals who might have been seeking medications for pain and other things went to zero. For like 3 months, nobody came through their doors that was any form of SUD relation. No one was going to health departments. They were closed. We had designed a system to have referrals from these entities. Law enforcement wasn't necessarily pulling over or responding to all these calls like they used to because of the fear of COVID and the spread. So we literally went to no referrals. We were still doing services on our mobile, still doing services in clinic. We were operating as needed, but we weren't getting referrals. And so that was really hard because then it was hard, but it also changed my thought process because I could no longer rely on somebody else. Now I have to think about how do I get that person? How do I go there? How do I take it one extra step where I don't have to rely on other people to help somebody, which that's important. Don't get me wrong. That's the way to do it. But I couldn't at that time. And so we did a couple different things. Again, with this unique relationship with the communications partner, we started a social media digital campaign. And so we devised keywords around substance use or specific drug words, specific, recovery words. And then we targeted the communities. And then so if your phone picked up, you were from that community, you were targeting these certain words, it sends you a digital ad. So how many of you have seen, and I know this sounds really creepy, don't get me wrong, but how many of you have been playing on, searching things at work? You go home, you're scrolling Facebook, and there's an ad for the things you were searching for at work because your phone and computer are all connected to the same connection at work. and now you're getting ads to buy whatever you were looking for. I've had some really interesting ads pop up as I'm researching different things for work on my personal phone. Well, it's because they're following us digitally. And so what happens is also if you go to a specific place, like the jail, like the alcohol store, or the school, different things, not schools, sorry. We can't target schools, but if you go to these certain places that we have geo-fenced, you get an ad too, just because you went there and you were in that area. And so it gives you this digital ad of, hey, and I can't show examples of them with the format they come in, but it shows a very similar ad to kind of those ads you've seen earlier about, hey, we're here to help you. Treatment is available, and it takes you to our mobile unit website. Well, so here's our report. So in June, we did almost 144,000 impressions. So that means 144,000 ads were sent out to people. Almost 200 of them clicked on those ads. 42 later returned to our website to find out for whatever more information. Now, this next number isn't right. So this next number on this report is to show how many people got the ad and went on the mobile unit. Well, with the way our mobile units are, they're very close to public places like the Dollar General. So we're really having to zone in on those geofences to get an accurate number of how many people are coming on the mobile unit. But that's what this does. And I'm looking into researching that I might actually be able to target specific areas. So if I know the specific area of town based off law enforcement calls is heavier in substance use related calls, can I then send that area ads about treatment? So I'm looking into that to even go into the neighborhoods. We've geofenced our medical marijuana facilities. I don't know that that's going to be the place to do it, but we're trying it and seeing what comes out of it. So those are some different marketing things that we've done because we've had to adjust. COVID has made us adjust and look at it differently. And so we're just trying to really think of how do we reach people. My next thing at the conference here was, how do we devise ads that are specific just to family to just call and get information? I don't want it to be an appointment. I don't want it to be a service, but how many families struggle with trying to figure it out? And all they need is a number to call and say, this is some information we can give you. And it might not just be about YCHC. It could be about services within the community. We're just answering a couple questions. And so I'm working on how do we target that group in a digital platform. So just something I'm working on. So as I said, mobile's not fast. Mobile doesn't serve millions of people in rural communities. So this is a glance of what we've done quarterly. So in March, April, and May, we were averaging in March and April almost 50 MOUD appointments. As you can see, our medical appointments went down a little bit. Our LPC appointments that were kept, we started out really rough. But in May, we were doing really well. We're doing a little differently on how we're making sure those individuals are keeping their LPC appointments. And then we're at, 2 new patients, 5 new patients, 4 new patients. And so, it's small. It's meant to not necessarily be a cash revenue. It's meant to be a solution in the community. And what was really important when we started this project was sustainability. And so I know if you go to, I have an MBA. And so when you look at these numbers as a business, you go, oh my gosh, that's not profitable. Absolutely right. Without the grant, we wouldn't be able to do what we're doing probably, or we would have to think differently. But it's about building capacity in these communities. And I'm really happy to say in one of those communities in Salem, we've built enough capacity through the mobile unit that we just purchased a building, plan to open it hopefully by the end of the year, early next year. Have to do some renovations. And because of this project, it proved that we needed to be in the community and we had the capacity. So I'm really proud of that. That's what the sustainability is for us, and not necessarily having large numbers currently, but just continuing to grow and continuing to build capacity. And again, we were always evolving. So here's my QR code example. I don't have it to actually do something for you, but again, law enforcement came and they were like, how do I get people to you? And so what we created was this business card. So this is a business card, two-sided, that law enforcement, EMS, whoever in the community can hand to a person and say, hey, I know you're having some issues and we're here to help you. And I know a great resource. And all that person has to do is click on that QR code with their phone and save our schedule to their phone. Because as we add another location, I am worried that the schedule is going to get confusing for not only individuals in the community, but our current patients. And so they click on that QR code, they say, hey, do you want to save this to your calendar on your phone? And they say yes. And it gives them the schedule and it reminds them every week where we're at. And so I'm hopeful that even just a basic calendar reminder, maybe they don't go this week, but when they get that reminder next week, they come. Again, it's about meeting patients where they're at, meeting them when they're ready. And it's really hard to meet them when you're not there, but maybe digitally we can be there and we can be that reminder. And maybe one day when they're ready, we're there. And so we also created a digital referral form. So that way our health departments and individuals in medical facilities could get consent from that person to send us their information, because it was really frustrating. We were hearing lots of brochures and lots of referrals were going out the health department stores, but we weren't seeing those individuals. And so now we have two entities who can contact that person and say, hey, we understand you have this issue. We have solutions and we want to be a part of that. And so we're not using that a whole lot, but we're using it when needed, and hopefully it can continue to grow. And so those are two things. And I seen someone ask about cell phones. You know, I have to say yes, whether it's a burner phone, a flip phone, whatever that is. So yeah, maybe they lose that phone or they get a new phone and they have to re-download it. But for as long as they have it, that schedule's on their current phone. Of course, services and all that, sometimes, the cell service isn't as great. But again, it's just that reminder on their phone, come see us. We're here locally in your town. You don't have to necessarily call, or you don't have service and you can't get there, but just come see us. So I know a lot of people will probably think differently on the cell phone, but that's my take. Before this position, I oversaw a treatment facility that did inpatient facilities, and I mailed off a lot of cell phones because they weren't allowed to have them in the facility. So we had to confiscate them, and I confiscated a lot of cell phones even after they went through the admission process, because they could still somehow get their hands on cell phones, whether someone brought it in or they hid it or whatever that is. But we dealt with a lot of cell phones. So that's where my experience comes from. Yeah, but running out of minutes or only having a flip phone. And again, that's why we wanted it to be just on their calendar. It's not a text message. It's not requiring data or minutes. It's on that calendar on their phone that pops up a reminder. So it's just like your Outlook calendar. It doesn't require any of that. We don't serve a lot of elderly, Lisa. Most of our population served is going to be that 20s, 30s, 40s. So I'm not sure how to answer that question, except for just a demographic of who we serve. So I know questions about impact, and it's really hard when you are talking these projects. Really, what is the impact? Well, I was really excited when the data came out earlier this year. So these are the number of fatal overdoses in Crawford and Dane counties. And I know these numbers are small, but they're not accurate. I know there's a lot more out there. These are just what's reported. As we all know, data is only as good as it's reported. But looking from a consistent foundation in 2019, you can see in Crawford County from 19 to 20, we decreased almost 50%. Dane County, we stayed the same. And it's not just us. There's lots of people in the communities doing work around this topic. And so maybe together through all of our efforts, we made some impact. I think so. And what's unique is when you look at this same time period of 19 to 20, I believe Missouri was seeing an increase of 17% as a state. We saw a decrease. We saw, we stopped that increase. That was our goal. And we seen that in that first year. And we weren't even really doing treatment yet. We had only been doing treatment for 3 months. from 19 to 20. So I'm really excited about that. As we all know, this 2021 numbers are going to be awful. Dent County's already doubled that. So I'm not thrilled about those numbers. So tips, one tip I always say, celebrate the successes and the wins. This data right here is a success and a win. And when we talk about SUD in the communities and treatment, a lot of the times it's hard to not think about the deaths or the number of overdoses or the theft or, all those other social determinants that drugs do to our communities. And so it's important that we celebrate the wins when possible, because our community needs to see the positives as well. All right, so there's my contact information. Do we have any other questions? Did I get all your questions, Lisa?